welcome to our special series. I'm Gargi Rawat. As part of our series Preventive Edge, an initiative by Fortis Healthcare in partnership with NDTV, today we put the spotlight on thalassemia and other major blood disorders in our episode Born to Thrive, Advancing Care in Thalassemia and Blood Disorders. Thalassemia, major genetic blood disorder, requires lifelong transfusions and chelation therapy, but today with medical advances like bone marrow transplants and emerging gene therapies, we are talking not just about survival, but about a future where patients can truly thrive. To explore this journey from prevention and early diagnosis to advanced treatment and long-term outcomes, we're joined by some of India's leading voices in hematology and bone marrow transplant. Let's introduce our panel now, and we have with us today Dr. Subha Prakash Sanyal, Director, Hemato-Oncology and BMT at Fortis Mulund, Dr. Vikas Dua, Principal Director and Head of Pediatric Hemato-Oncology and BMT at Fortis Gurugram, Dr. Neeti Krishna Raizada, Principal Director, Medical Oncology and Hemato-Oncology at Fortis Bengaluru, and Dr. Rahul Bhargav, Principal Director and Chief of Hematology, Hemato-Oncology, BMT and CAR-T at Fortis Memorial Research Institute, Gurugram. Thank you so much all for joining us today on this very, very important issue, which, there needs to be more awareness. And I'd like to start with you, Dr. Neeti, if you can tell us a bit about what are the kind of blood disorders out there.
So, when we talk about blood disorders, largely we can divide it into malignant, cancerous or non-cancerous. Now, when we look at cancerous disorder, it could be leukemia, which is abnormal cells which circulate in the blood arising from the bone marrow. It could be lymph nodal abnormality known as lymphoma, or it could be myeloma, which are plasma cell disorders. And then there are some rare conditions like myelodysplastic syndrome and myeloproliferative neoplasms. And then there's a category of benign disorders. An important one which you mentioned is thalassemia.
Okay, so those are the type of disorders that we have. But Dr. Sanyal, if you can talk about the different options there are in treatment of leukemia, is non-chemotherapy approach the way to the future?
Yeah, so standard definition of the chemotherapy means to treat the cancer. So any drugs which treat the cancer, we call the chemotherapy, right? But question is that there are a lot of non-chemotherapy options are coming in big way, and that we are already practicing. Suppose you called a acute promyelocytic leukemia. So that is, previously it was believed to be a very hard disease to treat. Nowadays, with the help of the totally non-conventional chemotherapy, like you use a tablet called Atra and an injection called arsenic, you can completely cure the disease. And the cure rate gone up to 95 to 100%, which you can't imagine in any cancerous process at present scenario even. Number two, in multiple myeloma, our conventional therapy is moved from the non-conventional chemotherapy to the different type of treatment like a monoclonal antibody, like a daratumumab, like a immunomodulators, proteasome inhibitor, steroids. So all these, the baskets of the treatment is changing in rapidly. And most importantly in today's world, the CAR-T cell therapy, which is the immunological therapy, which comes in the big way, which cures lot of diseases like a B-cell ALL, lymphoma particularly B-cell type, where actually no hope for the patient lives. So these are the major beneficiaries or benefits what we are seeing in today's world in the non-conventional chemotherapy approaches.
That's right. It's incredible to see the kind of advancements that medicine has made in these recent years. Dr. Dua, next to you, if we talk about diagnosis, and in children especially, early diagnosis can make all the difference, especially when it comes to thalassemia. If you could tell us a bit about that.
Absolutely. So when we talk about thalassemia, it's a genetic disorder. The parents are carriers, and if two carriers get married, there's a 25% chance that they may produce a thalassemia major baby. And once a major baby is born, he or she would require blood transfusion from the age of 6 months. And when you talk about a treatment option for these patients, it is always better to intervene early. Why? Because if these patients keep on getting blood transfusion, each and every unit of blood carries 126 milligram of elemental iron. So they get overloaded with iron. That iron goes to heart, goes to liver, goes to endocrine organs. And if you do a transplant, which is a permanent curative option for these patients, they will have complication because of severe iron overload. So if you want to intervene early, then you can have a better cure for these patients.
And is this widely known that you can have this intervention at an early age?
Yes, people know it very well. Sooner the better. It is always said that sooner is better. If you do a transplant for a patient who is, let's say, 1 or 2 years old, then the outcomes are much better as compared to somebody who goes for a transplant at the age of 15.
Okay, Dr. Rahul, now you've pioneered haploidentical transplants in India. So how has this changed the prospects for thalasssemic patients?
I think bone marrow transplant has gone a long way. If we see first transplant being done in India in 1990s, from there the availability of transplant, know-how about the transplants, the specialists about bone marrow transplants and the centers have grown by leaps and bounds. So a couple of years back we were doing say 2,000 transplants a year, now we are doing 5,000 transplants a year. And with the economic prosperity and the government of India stepping in, I think it has come to the ages that now every single person suffering from either from thalassemia or blood cancer can afford and can get a bone marrow transplant done. So we have to understand, in long back, my mother has got 7 brothers and sisters. So there's always a chance to find a donor. So there's a 30% chance that me and my brother can match. And there were 7 brothers and sisters, there was a large chances that they'll get a match within the family. But now with this shrinking world, shrinking families, if my kid has got no brothers or sisters, where do they get a transplant done? So pioneering and revolutionizing the scientific endeavors in understanding our biology, our immunology, has ushered us into an era where we can do half-match transplants. It means every single person tomorrow gets a thalassemia or a leukemia, have a donor ready. So it entails that every single person is now in the ambit of getting the treatment done. So it means that the survival is now increasing. So hard to treat cancers, there were 20-30% response rates. With a half-match transplant, it has jumped to 60%. So not perfect 100%, we are moving towards 100%, but then from 20 to 60% is a huge leap which we have taken.
So we really need more people to come forward and become donors as well. Dr. Sanyal, if you can tell us what steps have been taken to minimize post-transplant complications in leukemia cases?
Yeah, so as Dr. Rahul told, that bone marrow transplant actually revolutionary in our country. So a lot of options, lot of things we do. I very lovingly call it a micromanagement. So when you see the patient in your clinic, that you have to decide about that the patient needs transplant or not, and that very point of time you start preparing the patient for transplantation. So your therapy to control the disease will be in such a way that that should not be a stem cell toxic therapy. And another important thing is that you have to identify the proper donor and you have to galvanize the system, everything in the very right way. Number 2 is in our country, the hurdle of getting the successful bone marrow transplant is the infection point of view. So antibiotic stewardship that most of the hospitals now trying, and that should be doing in a very religious manner to prevent the unnecessary antibiotic usage and prevent the antibiotic resistance. Because that is the most important problem happens in the post-transplant scenario in our country. Number 2, we are now learning slowly in a big way about to prevent the graft versus host disease, veno-occlusive disease of the liver, so different type of complications of the bone marrow transplant in much better way. So we are moving much faster way. What Dr. Rahul told, I fully agree with him. And a lot of understanding about the other specialties of the hospitals, like infectious disease specialties, they also should come big way to form a team and a comprehensive hematology care, what I call about, which should be practiced in all the major institutes to get a very successful bone marrow transplant program in the country.
All right, well, let's talk more about, post-care. And Dr. Dua, if we can come to you, many of your pediatric bone marrow transplants involve very young people. So what unique surgical, immunological and aftercare challenges arise in thalassemia cases, especially for this particular age group?
Absolutely. So when we talk about pediatric age group, we are talking of patients from day 1 of life to 18 years of age. So when you are doing a transplant for a younger boy or a girl who is, let's say, 1 year of age, these patients may have complications. These patients may have nausea, vomiting, may have pain abdomen because of the chemotherapeutic agents what we have given. They may have pain abdomen because of mucositis. So older people, young adults or old age people can tell the problem. They can say that I have pain abdomen, something is wrong in my tummy. But for young children, for young patients, you have to presume that probably it is the abdominal pain which is bothering this boy or girl. That's why clinical skills are very important, and then you need to rely on radiological investigations. When you talk about the post-transplant challenges in these patients, there are chances of infertility. When you talk about transplant, when you do a transplant for somebody who's young, there is always a chance of 5 to 10% chance that that person may be infertile. That doesn't mean that he'll be sterile, but may be infertile later in the life. And you're not able to take the consent from the patient. You're going to take the consent from the caregivers. So later in the life, I had a boy who was transplanted at the age of 10. It was done in 2010, and now in 2025, he is 25 years of age, and he's married and he's not able to produce children. So he came to us and was asking, Dr. Dua, why this happened? But somehow, when he was 10, we were not able to make him understand that because of the transplant, you may be infertile. So these are certain challenges what we face when we talk about transplants for young children.
Let's talk about emerging therapies for blood cancers, especially patients with hematological cancers like leukemia, lymphoma or myeloma who cannot undergo stem cell transplantations immediately. What kind of emerging therapies would you recommend?
We elaborately discussed about transplant, which could be allogenic or autologous, in which we take your own stem cells and give it back to you. But when there are certain conditions based on patient's ability to have a donor, or there are certain other conditions in which they are early relapse, we think of alternate therapies. And there are a lot of new therapy options which have emerged in the recent past. One of them is bispecific T-cell engager. Now, this is a type of therapy in which it is tried on certain lymphomas and, of course, even myelomas, in which BCMA engagers or CD20 engagers are used. They are given as injectables and they work wonders. They are antibody drug conjugates, in which drugs are combined with an antibody which targets exactly the tumor cells. And then elaborately we spoke about CAR T cell. Now, CAR T cell is chimeric antigen receptor T cell, in which what we do is we actually extract an individual who has cancer, their cells, which is genetically modified outside and given back to the patient. And these are at this juncture used for B-cell malignancies. This could be B-cell leukemias or B-cell lymphomas. Now the indications are expanding to multiple myeloma as well, where it is BCMA directed CAR-T. We also have future direction of allogenic CAR-T, in which another source can be taken, where CAR-T can be modified, externally modified, and given to the person who actually has cancer. We are also thinking of natural killer cell related CAR-T. So CAR-T, NK cell is another therapy we are talking about. These are therapies which are actually almost in phase 2 and some areas phase 3 development. Not just blood cancer. CAR-T and CAR-NK are also coming up in solid cancers as well. So a lot of new exciting therapies coming up actually on a daily basis, and more expanding indications.
Right, that sounds very incredible, taking out blood and then, working on it and then injecting it back into the patient. So, Dr. Rao, that brings us, back to you to talk more about this. If you can tell us your thoughts on where gene therapy fits into all of this, especially thalassemia treatment.
I think the future belongs to gene therapy for each and everything, whether it be a single gene defect, whether it be a Duchenne's muscular atrophy or a spinal muscular atrophy or thalassemia or sickle cell. So we have to understand that this work has been in progress for almost 20 years. And it is now finally culminating onto the bench to bedside. It is moving towards the bedside, and it is heartening to see that hundreds of people have got a gene therapy successfully done in US, but still very expensive. It's got $2 million right now. But our own Indian endeavor, as we have done in CAR T cell. So CAR T cell was like almost $1 million in US, which has now been brought at 1/10 the cost in India. Self-made, make in India, made in India CAR T cell is now available. Similarly, multiple centers are working on gene therapy for thalassemia and sickle cell. So what it happens and what it entails is a future, because in thalassemia, the best results, as Dr. Dua said, is up to 10 years of age. Earlier you pick up, lesser the money you save, lesser the money you spend, and better is the outcome. But what about those people who are like 23, 25 years of age? Gene therapy is the miraculous thing for them. And gene therapy entails that I can modulate your gene of thalassemia, by which you are not being able to produce your cells. I can transfect with a virus and change that gene. So it means our ability is growing by leaps and bounds for the future cancers, and not only cancers, but for single gene disorders like muscle dystrophies, retinitis pigmentosa, brain disorders, and so on and so forth. So in all, if we see the revolutionized things which has happened in past 2 decades has ushered us into a new era of hope and giving us a light for these people suffering from blood cancers, where there was no role of them. They just happened to have these disorders. But the sciences and doctors are all there to change that in the future.
I mean, incredible. And also, India's well poised to, take advantage of this, isn't it? Just briefly.
I think India is well poised, not only because we now have a very, very clear-cut mission from the government of India of Make in India. The success story of transplants as being relied by 85 countries across the world, it's a story of success in itself. The second biggest success is the CAR T cell, which has now happened, and our CAR T cell is now going to Middle East and CIS countries and to South American countries. So for the first time, our cellular therapy areas has been well designed and well trusted, not by only us, but also by the world. So it was Make in India, Made in India, now it's Quality of India. So that is what is giving us a great boost, that the future belongs to India, and not every time you require a nuclear bomb to win over the hearts of the people, but the soft power of medical expertise is the one which is going to conquer the rest of the world.
In fact, India has become quite the medical destination. Dr. BMTs consider the curative treatment options for many leukemia patients, but if in your view, what are the top factors that determine the success of this treatment?
Yeah, so if you see that there are a significant number of patients which can be completely cured from the bone marrow transplantation. The patient group which actually needed to be bone marrow transplantation to be identified. But the problem in our country is that what Dr. Rahul told you very correctly, that it's just changing very rapidly. In 5-10 years, so many centers are coming, so many qualified people are coming, where many people who are trained abroad, they are coming back to the country. So there are a lot of boom is happening, what you can say. But the problem is that sometimes with awareness. So today morning, I'm telling one story to you. So I have a patient who needs bone marrow transplantation, who had 2 sisters, and both the sisters is a full HLA match 12/12. One sister staying in Mumbai itself, the other sister staying in some abroad. Both the sisters are not willing for giving the stem cells, having some doubts in their minds.
Really?
So it is not always the easy thing to do, but it is our job to reaching out to them, convince them, explain them, clarify their doubts, and bring to help them so that patients can get a proper donor. Dr. Rahul told that we had donor availability. Yes, around in family we get 20-25% donor. But in this 20-25% group also, we are facing these sort of social challenges.
And if you can tell us, what are some of the doubts, I mean, for our viewers, if they're interested.
So the first of the important doubts that if we give stem cells, it can happen some problem in my life later. We can get some, the family sometimes asks that we can get some mutations, some proteins, we can get some other cancer down the line. So these are not scientifically proven at all, but these doubts comes in their mind. Lot of Google knowledge is everywhere. People utilizes that.
And now there's AI knowledge.
I think they should talk with the experts properly. They should ask the proper questions, and the questions to be addressed properly, and that is the only way to do forward. Other problem is that there are many people believe that the bone marrow transplant is a very hard treatment. It is so hard that people will be totally crushed by the treatment. But what you have to understand that down the line, it is a curative option for them. What Dr. Vikas told, 10 years old, every time for blood transfusion, every month they are going to the hospitals. Now they are back to normal life. So I personally feel, when you go to cardiology, you see that people were very boasting about that. I have 2 stents, I gone to this hospital, this doctor done that. But in cancer, it's still a social stigma. So many people don't come out openly. They say that I had a cancer, now I cured the cancer, I won the cancer. That voices should come more, because those are the people who can be the mouthpiece of winning the battle of the cancer, I believe.
Maybe our next show we should have some patients also with you doctors who can actually talk about how they're living normal lives after undergoing treatment. So Dr. Dua, if you could tell us about the, after someone undergoes a transplant, you spoke a little bit about it there, but what is this outcome, how successful is it?
So when we talk about thalassemia, there are 2 ways. Either you follow the conventional track, you keep getting blood transfusion, you get iron overloaded, and by 2025 you lose your life. Or you go to a one-time solution, and that one-time solution is a bone marrow transplant. As we talk on today's date, the only permanent cure in India for thalassemia is a bone marrow transplant. And if we do a transplant for somebody who is a thalassemic, there's a 90 to 95% chance of cure. 90 to 95% long-term chance of cure. That means that patient would be thalassemia free and would be living a normal life. The chances is 90 to 95%. What does this mean? This simply means, let's say there are 100 patients who require transplant who come to us or go to any other center in the world. There is a 90 to 95% chance that they will do well. Out of those 100, 90 to 95 will do well. 5 to 10% can have complications. Complications can be a graft versus host disease, a rejection of the graft, you can have infections, you can have toxicity. But the chances is very bleak. So it is up to the family to decide whether they want to see the filled side of the glass or they go with that empty side and then they don't proceed for the transplants. It all depends on the family to decide whether they want to go for a curative option.
Right. And for that, there needs to be more awareness. So, Dr. Raizada, if we talk about, advocacy, education and access, so if you can tell us a bit about this and how can everyone, the caregivers come together to ensure this?
So first important thing is that what we can do is community education. We have belts of thalassemia, we have belts where we can actually do screening program and actually find out problems early. And if a patient, if they are already existing pool of thalassemia patient, we can educate them that there is a curative option, they should go for match. If it is not within the family, then they can actually access other registries where they have stem cells. That is one thing. Once the patient is already diagnosed, then we can educate the family. And if the patient is an adult, educating the patient itself to understand what are the expected side effects, what is the expected profile, as Vikas mentioned that in future the patient had infertility and he was not aware of. So in a similar adult patient, we can discuss these things with the patient and the family and the caregivers. Advocacy, well, understand that, it's not just the patient who's involved, the entire family. So when we are discussing, the entire caregiver pool has to be involved. And they are the people who are suffering during the course of the entire ailment. Finance counseling is another very important aspect. Financial assistance which can be provided, not for these kind of high-end therapies. All of our centers have assigned financial counselors who will talk to them. Also find out if there's social support which can work for them, financial support which can work for them, which is a journey which they have to take and how they can manage it. Where there are resource deplete areas, where patient cannot travel, there's transportation barriers or there are geographical other barriers. Thinking of satellite clinics and also thinking of telemedicine as a pool.
Well, thank you all for sharing your invaluable insights, and the message is clear: with prevention, early diagnosis, advanced transplant techniques and new treatment like gene therapy, the cure for thalassemia patients in India can be made available sooner than ever, and together we can help them not just survive but truly thrive. Thank you all for watching.